మీటింగ్ పెట్టాం మర్చిపోతాను.
Dr. Monica, I can stop the screen share.
Anand sir, good morning.
Morning, Anand sir. Sir, ఒకసారి మీ మైక్ టెస్ట్ చేసుకోరా, whether you can hear us and speak as well. Anand sir, ఒకసారి మాట్లాడాలి. We'll get to know if your voice is clear. నాకు ఎందుకో కట్ అయింది. How's this voice? ప్రీతమ మీకు కనపడిందా?
No sir, కొంచెం కట్ అవుతుంది. We can't hear you, Anand sir.
Anand sir, sir, how are you, sir? Anand sir, good morning, sir. Can you hear us, sir?
మీ వెనకాల విండో ఉండడం వల్ల మొత్తం డార్క్ అయిపోయారు. బ్రైట్
more than visual, it's the audio. Anand sir, ఒక్కసారి గట్టిగా మాట్లాడండి sir. We couldn't hear you when you last spoke. We'll just take a couple of minutes. As soon as we sort this out, we'll be.
Hello.
Sir, even sir?
Voice disturbance. Camera వచ్చింది.
మీరు ఒక పని చేయండి సార్, వీడియో ఆఫ్ మీరు వీడియో ఆఫ్ చేయండి. మీరు వీడియో ఆఫ్ చేసి చూడండి. వీడియో ఆఫ్ చేసి ఇప్పుడు మాట్లాడండి సార్.
అనంత్ సార్, ఇప్పుడు ఒకసారి మాట్లాడండి.
శబ్దం వస్తుంది మీరు మాట్లాడేది.
వినబడుతుంది సార్, కొద్దిగా బెటర్ వినబడుతుంది
సార్. కుదిరితే మొబైల్ నుంచి లాగిన్ అవ్వండి. విల్ బిగిన్ ద సెషన్. విల్ సీ ఇఫ్ యూ కంటిన్యూ టు హ్యావ్ అ ప్రాబ్లమ్, దెన్ యూ లాగిన్ ఫ్రమ్ ద మొబైల్. భాస్కర్ సార్ అన్మ్యూట్ చేసుకోండి.
Let him speak again. I think some signals problem on it, sir. Sir, matter sir, sir.
Good morning, Dr. Vamshi Kondle. Good morning.
Hello. మీ వాయిస్ రావట్లేదు నాకు.
వినబడుతుంది సార్ మీ వాయిస్ ఇప్పుడు క్లియర్ గా.
మీది మాకు వినబడతలేదు నాకు. ఆయన ఎవరో మాట్లాడుతున్నారు కదా, ఆయన వినబడతలేదు.
నేను సార్ డాక్టర్ శ్రీశైలం మాట్లాడుతున్నాను.
ఇప్పుడు మాట్లాడుతున్నారు, శ్రీశైలం మాట్లాడుతున్నారు.
నమస్తే సార్. నమస్తే.
ఓకే,
వినబడుతుంది సార్, మీరు స్పష్టంగా వినబడుతుంది.
డాక్టర్ శ్రీశైలం మాట్లాడితేనే వినపడేటట్టుంది.
అనంత్ సార్, మీకు ఫస్ట్ డాక్టర్ మౌనిక, డాక్టర్ ప్రీతి వాళ్ళు మాట్లాడేది వినపడాలి సార్.
ఓకే.
సార్ నమస్తే సార్.
నమస్తే 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 ప్రీతి.
హాయ్ సార్. హలో సార్.
హలో హలో.
I think we're sorted. Shall we begin, Bhaskar sir?
Yeah, please start.
Okay, okay, go ahead.
Yeah, and I'll just change the settings once. Good morning, everyone, and welcome to today's IAP Twin Cities branch postgraduate clinic. We bring you warm festival greetings. We know it's the auspicious month of Ramadan. We also have Easter Sunday today and have recently celebrated Hanuman Jayanti, Sri Ram Navami. We bring you festival greetings for the month of April. We also are happy to announce that we have crossed 300 early bird registrations for IAP Central Zone Conference, and we invite you all to be a part of this festival of IAP, which will happen in the month of June. Postgraduate clinic, especially on a single case, is very interesting. Often in the clinical meetings, you get about 20 to 25 minutes to discuss a case. And we often feel that we could have discussed a little more. We have a few nagging doubts, and somehow the entire system is not covered. But today we have the opportunity to cover the entire respiratory system, discuss the symptomatology in detail, the management, the differential diagnosis, and it's a wonderful opportunity for both practitioners and also postgraduates to learn completely the respiratory system today. I warmly welcome our experts today, Dr. Anand sir and also Dr. Preeti ma'am, for taking your time out and joining us. Welcome Dr. Srisailam, a Central IAP Executive Board member, and the entire list of participants who are here to learn and also participate actively in the discussions today. I now invite our President, Dr. Sunkoj Bhaskar sir, to give his inaugural remarks, followed by a few words from Dr. Srisailam, our Central IAP Executive Board member, guest of honor today, and then we'll straight away go into the technical session. So Bhaskar sir first, please.
అన్మ్యూట్ చేసుకోండి సార్. అన్మ్యూట్ చేసుకోండి.
Bhaskar sir, unmute చేసుకోండి.
Good morning all, and welcome you all to this 4th IAP Twin Cities branch monthly PG clinics on this auspicious day of Easter. And my festive greetings to you, all the participants. As Dr. RSV said, it's an auspicious Easter day today, and recently we had Hanuman Jayanti, Sri Ram Navami, and the holy Ramadan month is going on. And this time, for the first time of all the 4 PG clinics, first time we are presenting from a private institute, that is Paramita Children Hospitals. Earlier, first one we had from Natal. The second one we had from Gandhi. The third one last month was from Nilofer. Fourth, for the first time, a private institute, Paramita, has come forward for presenting this PG clinics. My special thanks to today's lead discussants, Dr. T. Anand sir and Dr. Preeti Nagaraj madam, for readily accepting our plea to be here on this holiday wherein they are supposed to relax with their family members. It shows their interest towards the academics and towards sharing their knowledge to the participants. And also my thanks to Dr. Srinivas Murki and Dr. Kiran, who had led this, who are guiding this presentation. Thank you, Dr. Srinivas and Dr. Kiran. And the presenter, Dr. Maunika, she is a DNB, post-DCH DNB student. I strongly feel she's one of the few best DNB candidates of this year. So our lead discussants will have free hand to have good discussion with her. But also, as we once again remind you all, IAPTCB along with Telangana State of Pediatrics, that is PATS, we are organizing a mini conference, that is Central Zone Conference, comprising of 5 states on June 10th, 11th, and 12th at Hotel Park Hyatt. Already 300 registrations are over. 10 registrations are over from since morning with the new tariffs. The good news is, dear postgraduate students who are participating in this PG clinics, your free bird early bird registration is valid until 30th of this month, and please make you avail of this benefit. And also, we have more than 10 workshops. We have more than 10 workshops, which are very interesting and are being led by the experienced faculty members. So do not miss this golden opportunity. Let's all together participate and make it a memorable one. And lastly, I thank all the participants for joining this PG clinics. That's a great encouragement to the organizers, that is IAP Twin Cities branch executive body. They're very eager and enthusiastic to run these academic programs throughout this entire 2022. Starting from IAPTCB clinical meetings, IAPTCB PG clinics, IAPTCB symposia, monthly journals, and whenever possible, physical meetings. So once again, thank you all, and wish you all a great learning experience and good sharing knowledge. Thank you once again. Over to next.
Thank you, Dr. Singh. Request Dr. Sri for a quick
Namaste. I first of all like to thank the Twin Cities branch president Sunkoj Bhaskar sir, RSV Sri Krishna sir, and Vamshi Kondle. And thank you for giving me this opportunity too. And today we have great teachers, Dr. Anand sir, Dr. Preeti Nagraj madam, and Dr. Srinivas Murki, who are one of the best teachers of the nation. And lucky to have that Zoom meets, because we are getting an opportunity to interact with them. And yesterday when I saw the message from the Twin Cities branch, I was a little bit enthusiastic. So in the morning, I set an alarm so that I don't miss it, because it looked something innovative. Because RSV, as he was saying, every time we used to do not get an adequate amount of time to interact. So I think a single topic on a single issue is very great. And fever, though it might sound simple, but be till the level of a great academician, it is a very challenging one. Fever is not that simple. Majority of the time, it's very complicated in many of the issues. And the learning point is from the parents, from the mother, who are the greatest teachers of any disease. So a patient is the greatest professor. You can learn a lot from them. Have patience in hearing to them. So many of the diagnoses can be made even without major investigations. I think today the panelists and the teachers are going to teach us how to use minimal diagnosis and more of a clinical orientation. So thank you. And it is a great learning experience for every one of us. Thank you. Thank you.
Thank you, Dr. Srichalam. We straight away move on to the case. I request Dr. Monica to share her slides. Dr. Anand sir and also Dr. Preeti ma'am to stop Dr. Monica whenever it is required and ask a few questions. And Dr. Monica, whenever you feel you can't answer anything, you have Dr. Kiran who will help you out. And I request all the participants to please type in the chat box. It's an interactive discussion, and I'm sure we have experts to tell us whatever queries we have in our mind. I hand it over to Dr. Monica. Good luck.
Good morning, everyone. I'm Dr. Monica, secondary DNB resident from Paramita Children's Hospital. I'm presenting the case under the guidance of Dr. Srinivas Murki, who is a senior consultant neonatologist and pediatrician in Paramita Children's Hospital, and Dr. Kiran Karthik Viranki, pediatric intensivist in Paramita Children's Hospital. So I present a case of 13-year-old male child who is a resident of Dilshuk Nagar, who was brought to our hospital with reliable informant being his mother, with chief complaints of fever since 25 days, cough since 25 days, and breathlessness since 1 day. History of present illness: child was apparently asymptomatic 25 days back. Then he had fever, which was low to moderate grade, intermittent, 2 spikes per day, which was not associated with chills and rigors, which was relieved with medication, and child was active during interfebrile period. And history of cough: since 25 days, which is insidious in onset, non-productive, no aggravating or relieving factors, with no diurnal or postural variation, with no history of any hemoptysis. Child was treated for this complaints on OP basis with antibiotics and nebulization. Then child presented to us with the history of shortness of breath since 1 day, which was sudden in onset, and it rapidly progressed to shortness of breath even at rest with no postural variation, and it was aggravated on lying down. There's history of loss of appetite, no history of weight loss or night sweats, no history of chest pain, no history of palpitations, no history of swelling of legs, facial puffiness, abdominal distension. There's no history of syncopal attacks and bluish discoloration of lips and extremities. No history of decreased urine output, no history of rash, no history of throat pain, no history of joint pains or joint swellings, no history of dental caries, no history of bleeding manifestations. There was no history of contact with COVID or contact with tuberculosis. There's no history of travel to any endemic areas, no history of loose stools or heat intolerance, and there's no history of unpasteurized milk intake.
Dr. Monica, good morning.
Good morning, ma'am.
So your main complaint is fever since more
Yes.
than near to 1 month. So where do you classify this fever as? What do you think this fever is?
It can be taken into pyrexia of unknown origin, ma'am. Chronic fever.
Can you define what is pyrexia of unknown origin? The new definition.
It is a fever of more than 101 degrees Fahrenheit, with lasting for more than 3 weeks, with not diagnosed even on OP basis, or 1 week of hospital stay with basic investigations and with thorough history and physical examination.
Wonderful. There is one more criteria where we can say it can be only nosocomial or HIV related neutropenic. So that classification also holds true. But as you rightly said that even 1 week of hospitalization, you are not coming to a conclusion after investigation of 3 weeks of OPS. And this cough which was there, which is sudden insidious onset, and it has no diurnal and postural variation. You have mentioned, is it not?
Yes, ma'am.
So child was okay all these 25 days with his cough and fever, but there was a sudden onset of breathlessness, and that has progressed to grade 4 in 1 day only, within 24 hours. So can you elaborate on what are the causes of sudden onset of dyspnea?
Sudden onset of dyspnea in a child with chronic history of fever and cough. It can be like any infectious causes causing respiratory causes like pneumothorax or emphysema, and sudden onset of breathlessness in cardiac conditions like cardiac tamponade, acute pericarditis, acute myocarditis.
Wonderful, yes.
And renal causes presenting with renal failure.
Yes.
And
so all these days, 25 days, the child was managing happily. In between, the child was active, playing. 25 days, the child was all okay. So there was some trigger, and that caused the child to land up with you, or the child had the acute emergency. Is it not? So high grade fever. And then you said there is a history of loss of appetite. So loss of appetite, is there associated loss of weight also?
No, ma'am. In this case, there was no history of any weight loss, ma'am.
So only loss of appetite is there. Okay. Yeah. So you think it can be a cardiac dyspnea? Cardiac dyspnea?
It can be.
Child had a cough. There was a history of cough for 25 days. Any respiratory cause which can cause a sudden onset of dyspnea in the child?
Sudden onset of dyspnea with the previous history of cough, mostly infectious causes leading to any cardiac component, cardiac involvement.
Exactly. Yeah. And respiratory causes, already said, it can be a pneumothorax, you said, very nice. Or the child has had an asthma where we can have an acute exacerbation.
Acute exacerbation of asthma.
Wonderful. Yes. Anand sir, you want to add anything at this point of time? Okay, let's go ahead with the history. Continue your history.
Past history.
Just a minute, Monica.
Yes.
Why can't it be pleural effusion?
There is no postural variation, sir. Like there is no relief of shortness of breath even on any lying on any lateral side.
So it can be there when the effusion is mild.
And it also generally it is gradual in onset, not very sudden in onset.
So which conditions you will see sudden onset pleural effusion?
Sudden onset pleural effusion. Emphysema, bacterial causes.
Okay, you can
like
see
empyema,
causes.
Empyema.
Malignancies too.
Malignancies.
So if you have sudden onset pleural effusion, you should think of malignancies. So pleural effusion, although in the initial stages it could have postural variations and all that, but if it is a large voluminous fluid, it may not have all the problems at all. So it is such a severe one that you are not able to breathe. So pleural effusion should also be considered, especially since you have a long history of fever and cough. Massive pleural effusion should come as one. Okay.
Suppose if it was a chest pain, associated chest pain, what all other DDs you can think about?
With history of chest pain, there's like pericarditis and
effusion.
Pleural effusion, pleuritic chest pain.
Yeah. So that is also not there. Okay. Go ahead.
Past history, there's history of chickenpox 2 months back. There's no history of any previous hospitalization. There's no history of measles and whooping cough.
Okay.
Family history: child is born to a non-consanguineous marriage. His second in birth order. Antenatal history: mother was registered with regular antenatal visits. There was she took regular iron, folic acid, and calcium. There's no history of hypertension, gestational diabetes, or anemia. It was uneventful. Natal history: the child was delivered at government hospital, full term, normal vaginal delivery, 3 kgs at birth, and child cried immediately after birth. Postnatal history: child was exclusively breastfed up to 6 months of age, and complementary speech was started at 7th month. Immunization history: child was immunized as per national immunization schedule, and BCG scar was present. And developmental history: child achieved milestones as per age. He is studying in 6th class with good scholastic performance.
Oh,
Monica, can you tell me? Can you tell me conditions? Hello.
Yes, ma'am.
Hello. Okay. 1 minute. Okay. Thank you.
Hello, Monica.
Yes,
will you elaborate on immunization which would prevent any respiratory diseases? All respiratory diseases with your immunization we can prevent. Can you tell? Can you elaborate that?
One is tuberculosis, ma'am, BCG, but it cannot prevent likely infection, but it can prevent the severity. And pneumococcal infections like pneumococcal vaccine, flu vaccines.
Your patient has taken national immunization.
Measles.
Yeah, measles.
Yes, measles, varicella, national immunization schedule. Varicella, measles.
Okay, Monica.
Mumps.
Monica, one question I want to ask in history.
Yes, sir.
Was there any pressure symptoms?
Sir?
Pressure symptoms were there or not? Like there was a fever for 25 days, sudden onset of deathlessness. Was there any associated pressure symptoms?
Pressure symptoms like.
Why do you ask pressure symptoms?
Pressure and I didn't get this.
Any dysphagia?
No, sir. No dysphagia. No history of any hoarseness of voice. There's no history of any neck pain or neck swelling.
Why do you want to elicit this history?
Like
sudden onset of the breathlessness, fever.
Sudden onset of breathlessness can also occur in some causes like retropharyngeal abscess or epiglottitis. And any tumors causing pressure on intestinal masses, mediastinal tumors causing pressure on the recurrent laryngeal nerve.
Yeah. Was there any puffiness of the face with enclosed veins?
No facial puffiness.
Why do you want to ask this? What do you want to elicit the differential diagnosis?
Facial puffiness, like to rule out failures, cardiac failure, and renal causes like renal involvement, renal failure can lead to facial puff periorbital.
Neck veins are distended, puffiness is there, sudden onset of the dyspnea is there.
Acute angioedema, sir.
Angio, any other? Superior vena cava syndrome.
Superior vena cava obstruction.
That is most important. Mediastinal mass, anterior mediastinal structures you should remember. Then that's why you have to elicit the pressure symptoms as well as see the puffiness of the face is there or not, and distended veins or engorged veins over the chest. So these are very, very important. Now, when you are going to approach a PUO case more than 25 days, so we have to think of the mediastinal lesions and as well as the lung parenchyma or pleura, pericardial, or first we have to think of the lung pleura, pleural effusion. That is the most important, sudden onset. So we have to rule out this pulmonary and cardiac and mediastinal and superior vena cava. So along with that, we have to think of the lymphomas, which is most common in mediastinal areas. So the sudden onset of the pleural effusion will be there, and sudden onset of the breathlessness. You have to think of this because the 13-year-old child, non-Hodgkin's lymphoma, may be present as a pleural effusion with prolonged fever. Tell me what are the causes of the fever without focus? How to differentiate FUO from fever without focus?
Fever without focus, it is generally within 1 week of duration with undiagnosed fever with less than 1 week duration with thorough physical examination and history, and also with basic investigation. And PUO is generally we label it as PUO when generally it is more than 3 weeks with
2 weeks, more than 2 weeks.
Two
weeks. And the fever without focus less than 1 week only.
Yes.
So that is the difference. Okay, why do you want to? There is a history of loss of appetite and fever is there, and when there is a loss of weight is there. What do you think of this? 3 things are there: fever, loss of appetite, then loss of weight also, and fever may be continuous or sometimes intermittent. What do you think of that?
Tuberculosis or malignancy.
Yes. Any other?
Fever.
Which can mimic like a tuberculosis. Which can mimic like a tuberculosis.
Fever, loss of.
Sometimes we may diagnose, or we may very oftenly will miss the diagnosis also. We'll miss the diagnosis. It mimics like a tuberculosis also.
Sir.
What do you ask the history of ingestion of unpasteurized milk?
Brucellosis.
That may mimic like a tuberculosis. Very common, no?
Yes.
That brucellosis clinical manifestation is similar to the tuberculosis. In India, maybe we come across for the past 10, 15 years. It is very common in Middle East, where they use the unpasteurized milk or the animal products. That is most important, no? And one more thing, the loss of appetite and the fever is there. Was there any cardiac lesions we can suspect?
Fever and loss of appetite, sir.
Yeah. And sudden onset of the breathlessness is there.
Cardiac, infective endocarditis.
Yes, yes. Sir. And is there any necessity to have underlying the cardiac lesion for infective endocarditis?
It,
Compulsory?
it
Or-
is it is not required.
Yeah. So less than 10 to 15% of the cases of infective endocarditis may not have underlying cardiac
Underlying
lesion, or other unknown causes may be there. So we have to think of the cardiac infective endocarditis, though we may not have the arthralgia or something when there is a PUO is there, FUO case. So that's why you have to elicit the joint pains or the fever and this loss of appetite. These are very, very important. Okay, go ahead. So any other things do you want to elicit in a history itself? That one only chickenpox you have told. Any other viral infection which can leads to the flaring up of the tuberculosis? Flaring up of the tuberculosis.
Measles and
Host factors.
varicella.
Varicella. Any other? Most common you are not telling. In pediatric, everybody bother.
Me.
And central government already imposed the routine to prevent that condition, the immunization we are giving.
Measles.
Yes, that you should not forget, measles. That's why here the government of India has introduced MR vaccine. No, so that is most important. That will decrease the immunity of the individual person, and it may flare up the hidden tuberculosis, occult tuberculosis. And other viral is the chickenpox or bacteria like fever or influenza. These all may predispose to the immune deficiency, and that may lead to the tuberculosis manifestations. So that you should not forget as a PG student, no. So and whenever you want to elicit, the detailed history is very, very important, not the knowing the direct diagnosis. The participation is very, very important, and the discussion, how you are answering the questions. Okay, go ahead. So that is most important in history itself. Okay.
Socioeconomic history, they live in a Pakka house. Four family members live in 3 rooms with separate kitchen and bathroom. Water source is tap water, only filtered, it's not boiled. And there are no pets in the house, and they belong to upper lower class according to the modified Kuppuswamy scale.
Yes, socioeconomic history remains very important, though this child belongs to the upper lower class. So if they are from the if they are into the modified or the newer modified Kuppuswamy scale, we need to look into the education of both the parents and, as you said, water source and their sanitation. Because that PM will increase at least 19 times the risk of pneumonia and 3 times the risk of bronchitis. So if there is a PM, if there is a low socioeconomic history, definitely, as sir said, that overcrowding and all those things, with the child having a immunocompromised state because of varicella infection in the past, more likely of tuberculosis, we can come to know, or any other super added bacterial infection, any other bacterial infection also could be there. Yeah, go ahead.
Nutritional history, expected kilocalories is 2000 kilocalories per day, observed is 1900, deficit of 100. Expected protein 58.5 grams per day with observed 50 grams per day and deficit of 8 grams per day.
Monica, this child being 11-year-old male, you have to do the Tanner scale. 13 years. Yeah. So you have to do the Tanner scaling has to be done Sometimes in the adolescent history, you have to do under the heads, where you need to know the eating habit, you need to know the activities of the child, how about his social behavior, whether he's going to the school. So personal history remains very important. And we have to mention the Tanner's. They never forget to examine SMR for the child around 13 years. No? So you have to see about how is the scrotum, how is the pubic hair, how is the axillary hair, and you need to have the torquidometer to measure the size. So it is always better, and always it is imperative when you have an adolescent child, be a girl or a boy, if you are not doing the examination properly, because then you are going to say in the general examination, head to toe examination, if you are mentioning there SMR, it is well and good. But in history, that under the heads, you need to mention about the child's activity, child's habits, all those things also have to be mentioned under heads, HEADDSSS. Okay, right, go ahead.
General examination, child is conscious, febrile, dyspneic, pallor is present, there is no icterus.
Change the slide, Monica, slide change. Slide change.
It is changed, sir, it is displayed. Ostundi, sir.
Yeah. Now it has come. Yeah. Okay.
Pallor is present, there is no icterus, no clubbing, no koilnochia, no lymphadenopathy, and no pedal edema.
Is there a cyanosis?
When
Is
you
there a
describe
cyanosis?
an examination, no lymphadenopathy, Monica, lymphadenopathy, how to say simple word like no lymphadenopathy? Was there any significant is there or not? When
No,
you say significant lymphadenopathy?
So significant lymphadenopathy,
When do you say significant lymphadenopathy?
Cervical and axillary more than 1 centimeter, sir. Inguinals more than 1.5 centimeters, sir.
Okay.
Cervical
axillary is not common, no. Common is cervical, superficial cervical and inguinal only. Then any other point? Only size you are telling. Any other?
Size.
Any other? More than two
with
lymph nodes.
More than 2 contiguous lymph nodes.
And when there is a tenderness,
generalized lymphadenopathy.
Yeah.
Generalized lymphadenopathy is two non-contiguous.
Non-contiguous.
Not contiguous. Remember that is non-contiguous. Yeah. So there are no lymphadenopathy.
No.
Okay.
Head to toe examination. Skull is normal. Face, there is no deformities. Eyes, cornea, and lens are clear. Nose, ears, they're normal. No discharge. Mouth, oral mucosa is normal. Neck is normal. Extremity is normal. BCG scar is present with no subcutaneous nodules, JNV lesions, or osseous nodes. Chest is normal. Abdomen is normal. Spine normal. No gibbous, no vertebral anomalies. External genitalia normal. There is no rash and no external markers of tuberculosis are present. No bony tenderness, and there is no secondary infection of chickenpox lesions.
Monica, here in the mouth, you have said oral mucosa is normal. You kindly mention about the dental caries. Anything is there on it, that you have to mention?
Yes, no dental caries.
Second, one more thing what I wanted to say was, you have nicely elicited and mentioned about the JNV lesions and the osseous nodes. Can you tell us other features of infective endocarditis? Anything in the eyes, anything else you can say?
Rod spots, ma'am, splinter hemorrhages.
Yes, good. Were they there?
Ma'am?
Were they there?
No, ma'am, no.
No. Okay. Okay, go ahead.
Anthropometry, observed weight is 43.7 kgs, expected is 45, and child is around 58th centile. Z score is -0.4. Height is 146 centimeters, expected is 154. Centile is 10 to 25th with Z score of -1.56. Observed head circumference is 50 centimeters, which is around 50th centile. BMI is 20.6, expected is 18. It is around overweight with Z score of 0.63.
Okay.
Monica, 1 minute. What are the clinical features of infective endocarditis? The most common clinical we have to suspect in history itself and examination. You are asking, you are mentioning only Janeway lesions and oscillus nodes, which is not they very commonly will come across.
History.
But what are other features suggest you of?
History.
What other features?
Fever, splenomegaly,
Yes.
splinter hemorrhages, rod spots, Janeway lesions, oscillus nodes.
No, you are telling what? Where findings you are telling? Most important at bedside, you will examine the patient daily, you will do the rounds.
Cardiac.
Another point, changing of murmurs. Changing of murmurs is very, very important.
Onset of new murmur or change in the existing
that is
murmur.
Most important. No.
Cardiac.
Yes, Monica, more than 70% they will have the fever. More than 70%. Then another 11% they may have the splenomegaly and changing of murmurs, more than 11 or 12% if you take the symptomatology of infective endocarditis. So that is most important, not the Janeway lesions, oscillus nodes, and these are all hypersensitive reactions. So we'll come across with rarely, not common. And rod spots, all these things for the routine, the teaching purpose only. And when you see the observation, very less common when you compare to other symptomatology. So that is, do you, can you say any criteria to diagnose the infective endocarditis? Any criteria?
Modified Duke's criteria.
Yes.
What is that criteria, at least? PG level.
Major and minor criteria, sir. Major criteria, blood culture positive.
Yes.
And
yes. Second one is there. Second one.
Blood culture positive and
echo findings.
Echo findings.
Yeah, Duke's criteria. Modified Duke's criteria.
Minor.
Yeah. Okay, go ahead.
Vitals. Temperature is 100.5 degrees Fahrenheit. Pulse rate is 120 per minute. Low volume. Regular in rhythm. No specific character. All peripheral pulses felt with no radioradial or radiofemoral delay. Blood pressure is 100/60, measured in right upper limb in supine position. Respiratory rate is 30 per minute, and JVP is elevated, measuring 9 centimeters of water.
Okay.
Respiratory system examination.
What does it give to you? In general examination, did you come to one conclusion? Because you said JVP is raised. So, what are the different waves in the JVP? You can tell? What are the different waves which we see in JVP?
There are 5 waves, ma'am. A, C, X, V, and Y. A is due to atrial contraction. C is due to bulge of tricuspid valve. X is due to pulling of tricuspid valve during pulling of tricuspid valve back, and V is due to venous filling of the atrium, and Y is due to diastolic filling.
Okay, yes. So diastolic descent, agreed. I wanted to know now, before going to the systemic examination, from the history, from your examination in the general examination, did you come to one conclusion? Yes, what it can be a likely possibility? Do you still think that respiratory system is the first system you want to examine, or you feel that there is something else to it? Because in history you said it can be a cardiac cause of the dyspnea. So do you think? Yeah.
It can be respiratory or cardiac, ma'am. Respiratory, like fever, cough, and sudden onset of breathlessness, like it can be any massive pleural effusion.
And 1 minute. Is it a primary disease in the lungs or cardiac? How do you say that? Is a primary lesion in the lung or cardiac?
Primary lesion, it can be a lung leading to cardiac involvement, mostly.
That is most important. No, that is most important.
So in admission, the child was in failure. That is it, no?
Yes.
Is it not so?
Yes.
Yeah. Okay, go ahead with your respiratory examination.
Respiratory system examination, upper respiratory tract, there was no nasal flaring, no deviated nasal septum, there's no sinus tenderness, pharynx was normal, throat was normal, there's no congestion. Lower respiratory tract examination on inspection, shape of the chest is normal, trachea appears to be in the midline, chest movements were symmetrical on both sides, apical impulse was not visible, and there were no scars or sinuses or no engorged veins. On palpation, trachea is in the midline, slightly deviated to right. Apex beat is hyperdynamic, diffuse, it could not be localized. There's no chest tenderness or intercostal tenderness. There's no chest expansion was equal on both sides. Vocal phometus was equal on both sides except absence in the left infraaxillary region. On percussion, direct percussion, it was resonant. And it was resonant over all the areas except a dull note in the left infraaxillary area. On auscultation, there were normal vesicular breath sounds were heard with no added sound, and there were decreased breath sounds in the left infraaxillary region, and vocal resonance was equal on both sides except decrease in the left infraaxillary region.
Right.
Is there any stony dullness? Only for dullness on percussion of the left part of the lung.
It was like a stony dullness.
Stony dullness on the left side only, the particular areas.
So air
the
entry is
stony
decreased,
dullness
breath
means
sounds are
respiratory
decreased. You
effusion.
have air entry is decreased, breath sounds are decreased. Dull note is there in the isolated only in the left infraaxillary area.
Yes, ma'am.
What do you think it is? Go back now. Go one slide back now, please. Yeah.
It could be a pleural effusion.
It can be a pleural effusion.
Why the apical impulse is they shifted?
It is due to cardiac.
And effusion also, no? Pleural effusion.
Pleural effusion, generally in a massive pleural effusion, or it can shift to the opposite. It can shift, sir, but here only in the left infraaxillary region.
Okay. And it is a diffuse also.
Yes.
You cannot localize.
Yes. Cardiac examination on inspection, there is no.
Where in the respiratory, go back in the respiratory examination. Let me just again see. What is egophony?
Egophony is when we ask the child to
where do we see this egophony? You have done VF, agreed, vocal frequency, vocal resonance you have seen. Any other thing, if you are thinking it is pleural effusion, and any other thing which you could have done? What is whispering?
Whispering pectorloquy, when we ask, when the child speaks and when we auscultate, it is like a whispering sound we can hear on examination.
Other PGs you can put in the chat box. What is WP? What is egophony? We get egophony in which conditions? Where do you? What is actually egophony? Bleating of the goat sound, no? Like that you will have that bleating sound. Where do you get such sound? In which condition? Do you agree that at this point of time there is a pleural effusion? What are the findings in favoring of pleural effusion? Your trachea was in midline only, slightly shifted to right, which is normal only. Okay, these all dull note and all those things. Can it be only a consolidation? You have said only dull note. You didn't mention about the stony dull note. What are the features favoring a pleural effusion, or what are the features only it is a sympneumonic effusion? How do you define a sympneumonic effusion or a paramnemonic effusion? What it is?
Sympneumonic effusion, generally it is consolidation leading to pleural effusion. Along with pneumonia, the pleural effusion is present.
Can it be there is a possibility in this case?
Yes, ma'am. It can be, but consolidation, there has to be any bronchial breath sounds or and vocal resonance and vocal parameters, generally it will be increased.
Yeah, so that is
That-
one reason where it maybe that is not a consolidation. Yeah. What is a paranymonic? You
Paranymonic
said pneumonia.
paranymonic effusion, there is a other causes, like any cause can lead to pleural effusion. Like generally along with consolidation, there will be a pleural effusion. And also
PGs, you can put it in the chat. Okay, go ahead. So at this point of time, with the respiratory system examination, with your history and general examination, do you come to one conclusion? Anything you want to conclude?
It can be infectious, infectious cause of pleural effusion.
Okay, good. Go ahead. Yeah.
How do rule out the viral which may have the pleural effusion also? No? How do rule out? There are also we have the effusions, fever.
Viral, generally it will be a multi-system involvement, sir, with generally acute phase, not a chronic phase, chronic fever.
Acute phase only, the viral fever like dengue may have the effusion. No, that is a short duration, not like more than 2 weeks. No, we cannot get that. So that is a point against the viral. So we can rule out the viral cause for the effusions. So the third space effusions are more common now in a dengue fever, in the pericardial or peritoneal or pleural. So along with the short duration of fever and body pains, malaise, you can think of the dengue or no. So that we have to rule out. Okay, go ahead.
Cardiac examination on
inspection. What about the trobes area? What happened to the percussion in the trobes area?
It is resonant, no?
It's resonant. Okay.
On cardiac examination, inspection, there is no precordial bulge. Epical impulse is not visible. No visible pulsations, no scars or sinuses. There are no engorged veins. Palpation, apex beat is hyperdynamic, diffuse, could not be localized. There is no parasternal heave or thrill.
Monica, you go back to the, why do you mention no scars or sinuses? What are the common condition where we will get the scars and sinuses in the chest? Can you elicit?
Sinus.
Is it common in pediatric?
No, sir, it is rare.
And what condition it suggests?
Sinuses on chest, tubercle.
The chest is common. Is it common? The site. Sinuses are more common in the neck. Tubercular sinus.
Sinus are
and in abdomen. Not in the chest, no.
Chest.
Scars. What operations might have?
Post-cardiac.
Yes. That congenital heart disease.
Surgeries, congenital heart disease, post-cardiac can lead to.
There is only one point you can mention here to support your finding. No scars, nothing, but no sinuses. You should not mention. It's not common when compared to the neck region and the abdomen. And engorged veins, okay, you can rule out the mediastinal tumor or superior vena cava syndrome. Yeah, we can think of that. Okay, go ahead.
Percussion, upper border corresponds to second intercostal space, left heart border, fifth intercostal space, 2 to 3 centimeters lateral to the midclavicular line. Right heart border, fifth intercostal space, 1 to 2 centimeters lateral to the right sternal border, which indicates a mild cardiomegaly. Auscultation, mitral, tricuspid, pulmonary area, and aortic area. The S1, S2 are.
What has happened? Wait. In the percussion, what has happened to the second space dullness?
Second
upper border was corresponding, but second space dullness is there? Any second space dullness is there? If it is there,
no second space dullness.
It is not there.
Pulmonary
Hypertension.
pulmonary arterial
Hypertension, no, pulmonary hypertension.
PH can be there. Pulmonary artery hypertension can be there. Your right heart border was corresponding or lateral to the right sternal border, you said.
No.
And left heart border is lateral to the it is so apex is not corresponding to the so it is beyond that. What are all the conditions where you can you tell what are all the conditions from this percussion? What do you conclude?
There is a cardiomegaly, ma'am, mild cardiomegaly, and apex is shifted. Apex is shifted out.
Down and out.
Down and out. So it can indicate left ventricular dilatation, left ventricular hypertrophy or dilatation.
Yes, good. But one more thing I wanted to put on Monica is posterior percussion you have not done. Be it in a respiratory thing, you have not mentioned anything interscapular. What about the Grocos triangle? What about Garland triangle? Many things are there. Trapeze area you mentioned, but posteriorly you haven't.
Scapular, intrascapular.
Okay. Right. Okay. Thank you. Yeah.
Auscultation, mitral area, tricuspid area, pulmonary area.
Monica, 1 minute. Oscar, this percussion, no, regarding the cardiac dullness, that indicates the cardiomegaly, no. So what could be the possibility of the cardiomegaly there by this finding? What are the differential diagnoses you can think of?
Cardiomegaly can indicate any cardiac like volume overload or pressure overload, sir. Can be concentric or eccentric hypertrophy. Cardiomegaly in this child, it can be due to pericardial effusion or also hypothyroidism, or hyperthyroidism.
Pericardial effusions.
And dilated cardiomyopathy, but there is a generally a chronic history of breathlessness, but here there is sudden onset and
Good, go ahead.
Auscultation, mitral in all areas, S1, S2 are muffled. Left, third, and fourth intercostal space, we can hear an adjacent systolic murmur, which is a grade 3/6, low pitch. There was no radiation and no conduction. Upper abdomen, it was soft with palpable.
Wait. No, wait. So muffled heart sounds with cardiomegaly on your percussion with muffled heart sounds and an ejection systolic murmur. What do you think at this point of time? You want to conclude anything?
Ma'am, it could be a pericardial effusion leading to a cardiac failure, congestive cardiac failure.
Yes, good. So you got the diagnosis on your examination with history and with your general examination. You are thinking the child, because in the history you are seeing that the child is having a failure sign, sudden onset of breathlessness, JVP was raised, and here you can conclude because of your percussion and your muffled heart sounds, you can conclude that yes, that can be a pericardial effusion. Okay. Yes, is it not so? Yeah.
Yes.
Monica, 1 minute. Yes. What is the reliable finding to suggest the congestive heart failure, cardiac failure? Physical examination.
JVP is elevated, sir. With congestive hepatomegaly.
That is a tender hepatomegaly. The reliable finding. That is the most important primary. Then next is the displacement of the apical impulse. Yeah, third one
is
more
thing you have said. One more thing you have told about is your pulse. What will be the pulse? You classically said low volume pulse. You had mentioned some 100 rate. You had said. So what is the classical pulse we see in your Cardiac failure. Is pulses?
Cardiac failure.
Alternance. You said
Is
it can be a low volume
pulses,
pulse, or it can be not.
Al-
Alternate.
pulses alternate.
You said low volume pulse. You have mentioned that also. Yeah. Right. So abdominal examination, anything is there?
Hepatomegaly is there, ma'am. Liver 3 centimeters below the right postal margin, soft, tender.
As sir said, that is the class. That is a classical presentation of a tender hepatomegaly.
Tender
Suppose
hepatomegaly.
liver is not palpable. Can you do something to say yes? It can be still a failure. What is it? Another sign which we call
hepatojugular
reflux. What is it?
When we
How do we elicit it?
when we press on the when we press on the liver for more than 30 seconds, there will be elevated JVP of more than, if there is an elevated JVP of more than 3 centimeters and it is sustained, then we can call it as raised JVP.
1 minute, Monica.
Yes.
No, you have not mentioned about this hepatomegaly. One more thing, no, is it a known condition or is a physiological condition or pathological? How do you differentiate pathological hepatomegaly and physiological hepatomegaly?
Liver span, sir, and
yeah, you have not mentioned no liver span.
Liver span was 9 centimeters.
Yeah, that is most important. No, push down condition. No, the pleural effusion, pneumothorax, all right side, that may leads to the pushing down hepatomegaly, and sometimes aberrant lobe, radial slope also. So we cannot label it as a pathological hepatomegaly. So the liver span is very, very important. You have to mention here. Otherwise, you cannot deal with the cardiac or pulmonary conditions, both. That is most important in physical examination. Next.
So summary
examination, though here you have mentioned no abnormality detected or whatever. See, when the child has had a history of fever since past 25 days, history of weight loss, all the findings like you have done in the inspection, palpation, percussion, auscultation, in that methodology, like we have, you have to mention. In the CNS, we are going to say about the higher mental functions, about the cranial nerves, everything. At least on the headlines, you should put for all the PGs, because the PGs are here. You never do that. In the long case, you have to mention. There is a possibility that the child have an altered consciousness. There can be a chance that the child has a, if you are suspecting, as sir said, there is a likelihood that there can be a tuberculosis. All the features of CNS tuberculosis, you can see. Talk about the cranial nerves, about the motor examination, cranial nerves, reflexes. All these things have to be mentioned, though it can be normal. It is normal, I'm agreeing, but under the headlines, because you tend to forget in the final exams also. So don't do that. It's okay. So CNS is normal, you want to say.
Yeah,
right.
always
Okay,
you should not tell when you are thinking of the approach to the case of FU, no, and you are thinking of the tuberculosis origin and infective pathology. And this case may have disseminated, no, the CNS manifestation may be there. So you have to think of the fate of the primary complex, the one's focus. That may lead to the CNS involvement or leads to the kidney, bone, or any other organs. No, that is most important. No, the Valligren's timetable. So the CNS, we cannot say like a blanket statement, CNS is no neurological deficit or something. So it is very, very important in Asian countries. You should not forget about the tuberculosis in and out. And when you are in a Middle East, no, you should think of the brucellosis. And in India, it is the tuberculosis. So it can attack anything, any organ. So that we have to recollect the timetable of the primary complex. So the CNS in detail, Dr. Preeti Madam, she told, no, you should not say like that as a PG level. Though it is a normal finding, but we have to tell because the long duration is there, sir, and there is a chances of involvement of the CNS and tuberculosis meningitis or disseminated tuberculosis, whatever like. So the CNS identity, the methodology you have to follow, and you have to elicit and you have to express. That is a pattern of the presentation of the PG. The normal thing also you have to focus. Presentation is most important as a PG. Whether it is MDPC or MSPC, DNPPC or MCHPC. That is most that concept you should develop. So that is a okay. You tell the summary.
A 13-year-old male child came with complaints of fever, cough, and loss of appetite since 25 days, with sudden onset of breathlessness since 1 day, which was aggravating on lying down, and history of chickenpox 2 months back. On examination, child is febrile, dyspneic with muffled heart sounds, and with ejection systolic murmur and tender hepatomegaly.
By this, what is the priority of the differential diagnosis?
It could be a infectious cause, sir. Chronic infections like tuberculosis or
any other granulomatous disease.
Brucellosis.
Yes.
And any chronic infections, viral infections like chronic bacterial.
Yes.
And any immune related, but we have ruled out there are no external markers of infective endocarditis, so we have ruled out infective endocarditis. And other immune autoimmune conditions like SLE also can cause, but there is no rash or organomegaly, and we have ruled out that. And it could be there could be a possibility of malignancy like mediastinal tumors or lymphoma.
Yes. Sometimes what will happen, the common diseases may present as uncommon very rarely also. So that is the purpose of presenting the case. So that way you can discuss the differential diagnosis as per the priority basis itself. Infective pathology, then neoplastic pathology is there or not?
PGs, at this point of time, you type your differential diagnosis, PGs. In the chat box, you can mention what are all the differential diagnoses you are thinking other than what Monica was narrating. So what are all the differentials you are thinking, Monica?
Yeah, you go. Slide change.
So it's a case of pericardial effusion with mild pleural effusion presenting with respiratory distress with possible etiology of tuberculosis, brucellosis, or lymphoma.
Yeah.
Good.
Shall I proceed?
Okay.
Investigations, complete blood picture was done where hemoglobin was 10.3. Red blood cell count was 4.2 with PCV of 31. Total leukocyte count was 4,660 with neutrophilic leukocytosis. Platelet count is 3.9 and smear was normocytic and normochromic.
Okay.
CRP was 18.5 and renal function tests were normal with serum electrolytes were normal. Liver function tests were normal.
Okay.
Sputum for AFB and gene expert were negative, but Mantos was positive with induration of 24 millimeters, and DSR was 30 and 80. HIV and HBS AG were negative.
So Manto positivity is of very much relevance here because the child has had a history of chickenpox. So any exanthematous fever, you will have a false negative Manto, but here you have a false. Here you have a Manto positive in a young adolescent boy. So what is the significance of Manto? Say the Manto was 5, Manto is 10, Manto is 15, Manto is 25. How do you interpret in different conditions? Yes, Monica?
If the Manto is more than 5, it can be positive in immunocompromised individuals or any immunocompromised, any history of drug intake and with significant history of contact, and more than 10 mm in a less than 4-year-old child with history of contact with TB and where there is a clinical suspicion, and when the child had visited any when the child is in contact with a sputum positive TB and HIV individual with tuberculosis, and when the child visited an endemic area with pulmonary tuberculosis, and more than 15 mm, it is positive when it is in a more than 4-year-old child with any of conditions.
So what happens
And
in the
more than
atypical
10 mm,
mycobacteria?
Yeah.
more than 10 mm.
Atypical mycobacteria. Madam is asked.
Atypical mycobacterium, there about mantum. Atypical mycobacterium, generally it is negative.
It will be negative.
Negative.
No, not at all negative. How much value should be significant in
value?
I don't know, 5, 10, 15, 20, how much?
More than 20, 25 now.
It's more than 15, yeah.
More than.
So you tell me how do you define a contact, the newer definition of contact?
Contact with TB when the child is exposed to a smear positive active tuberculosis case within past 2 years.
2 years, okay.
Any more elaborate this thing? Suppose the child is
and also
duration of stay or with the contact, anything is there?
Spending one night with an sputum positive case.
Yes. Right, go ahead.
Monica, okay, you are telling the investigations. Okay, afterwards, okay, go ahead.
In this child, ASO titers were 400 international units per ml. B. Felix, Brucella antibodies and viral test was negative. COVID IgG antibodies were positive. CUE was normal, and smear for malarial parasite is negative.
So ASO, wait. That ASO and does that ASO has a significance? 400. How much it should be? Why did you get that ASO done?
Actually, we were also thinking of rheumatic fever. No?
Rheumatic fever. Okay, then what are all
no
the
joint
features?
pains? No joint pains or
no joint pains, no rash.
Yeah, it is. How can
fever
you
was there, but the child had a fever.
Chronic fever.
Tell me about the modified Jones criteria.
Major and minor criteria, ma'am. Major, minor, and essential criteria. Major criteria includes carditis, erythema,
which is there in your condition. Carditis is there in your condition.
Carditis and minor subcutaneous nodules, migrating polyarthritis, erythema marginatum, and chorea. Minor criteria, clinical criteria of fever and arthralgia. There is fever. And minor laboratory criteria, CRP, increased ESR, prolonged PR interval, and essential criteria, ASO titers, and previous history of scarlet fever or any streptococcal infection.
Throat culture.
So all things are fitting into rheumatic. No. You have minor criteria as well as a major criteria. Is it not?
But you cannot expect
pericardial effusion is.
It is a part of carditis or not? Do you believe or not? Carditis is there, no? So it's a major criteria. Past history is not there. Suppose past history was there, a different story. Here you have a major criteria, minor criteria, essential criteria. Is it not so?
Yes.
What is not significant here? Why you can't say that it is rheumatic?
Rising ASO titer is important, Monica. Rising
ASO titer.
That is most important along with the CRP and anti-DNA.
And the murmur, if you are saying carditis, if you are talking about the endocarditis, the changing murmurs should have been there. So musical changing murmurs, that is not there. But your ESR was raised, your CRP is raised, ASO is raised, and fever is there. Now you have to have that high risk and a moderate risk, no? And the echo finding, the criteria of Jones criteria you have told is that old thing, the newer one, if you can tell me, depending upon the echo criteria, moderate risk and high risk, no? What is that criteria? What is that Jones criteria?
Low risk and moderate risk with like population with in low risk population with polyarthritis with CRP of more than 6 and
30.
ESR of more than 30.
30.
Yes, ma'am. And high risk population with even with oligoarthritis with CRP of 5 and ESR of
Yes, sir, even less than 30.
less than 30.
30.
Less
No, no.
than-
But
less than 30.
what about the echo?
Echo criteria,
Echo findings, no?
mitral regurgitation and aortic regurgitation, like jet velocity and
What is happening to the jet velocity?
jet velocity more than 2
centimeters, yes,
2
right?
centimeters.
Peak velocity is more than 3 centimeters in pansystolic in mitral. And aortic, you remember, aortic you will have all this in all 4 views you will have the jet velocity more than 2, the jet length more than 1, and peak velocity more than 3,
more
same.
than 3.
But that will be a pan diastolic. There you will have mitral, you remember pan systolic. So these are the newer criteria which you need to know the echo findings. Is it not so?
Yes.
So revised Jones criteria we call it, right? Go ahead. What about the echo? Achha, okay, go ahead. Yeah, describe this X-ray.
This is a chest X-ray PA view, which with good exposure and well centered. Trachea is in the midline. No bony deformities or no fractures, and soft tissues are normal. With mild pericardiac, it could be a right paracardiac haziness is present with mild with cardiomegaly. And costophrenic, right costophrenic is costophrenic and cardiophrenic angles are free. Left cardiophrenic angle is slightly obliterated with right left
The haziness is there, no, left side. Haziness is
left
there,
side, yes.
yeah. Haziness and the
obliteration of the CP angle.
And mild cardiomegaly is there. Yeah.
Cardiomegaly with what type of the apex is it? Describe that cardiomegaly, no?
Left, it is like a rounded left left ventricular apex.
No, the radiological finding, how to describe this? The cardiomegaly is there and obliteration of the CP angles.
Round.
Is there any term?
Right.
Particular term for pericardial effusion? Radiological finding? Okay. So what are the metabolic causes of pericardial effusions? We are thinking only infective pathology and neoplastic and traumatic. What are the metabolic?
Metabolic causes like
you already mentioned in the history, puffiness of the face,
cardiac,
urine output, uremia. Uremia is very, very important. No, hypersensitive to reaction is there. And hypothyroidism. Myxedema. They die up with massive pericardial effusion in hypothyroidism. The adults and even the pediatric also. This is most important. And the third one is a chylothorax. Chylothorax also will have the pericardial effusion. So metabolic. Okay. That. And you did find any gastric shadow? Fundal gas is not there on the left side?
Slightly.
Yeah, it is not there. Okay.
Not.
Yeah. Okay. Echo findings.
2D echo shows fluid around the heart.
Okay, so I think confirming that pericardial effusion is there.
Yeah. Okay, the cardiac findings. Any other supportive lab investigations? No, okay. You tell the findings of the echo.
Cytosolitis, levocardia, IVC was dilated and non-collapsible, collapsing right atrium and right ventricle, dilated right atrium and right ventricle, good biventricular function, no LVOT or RVO, right ventricular outflow obstruction, massive pericardial effusion is present.
Yes.
This is HRCT chest. Actually, it is after pericardial synthesis. There is a mild pericardial effusion with multiple enlarged, discrete, and confluent mediastinal lymph nodes with a possibility of mediastinal TB or lymphoma.
Yes.
Sir, the intrathoracic lymph nodes are commonly involved in tuberculosis. Intrathoracic lymph nodes commonly involved in a tuberculosis because we are mentioning the mediastinal lymph nodes. Any other?
Paratracheal.
Yes.
Yes, good.
Yes. Next.
Pericardial.
Paratracheal.
Aortic.
Hilar lymph node.
Paraortic.
Paraortic.
Hilar.
Hilar, paraortic, preaortic.
Are intrabronchial lymph nodes. And most important piece, the precarinal lymph nodes. You are not telling the PG level, you should know all these things. No, the precarinal lymph nodes are very, very important, which is most commonly involved in tuberculous infections. So the paratracheal, hilar, intrabronchial, and precarinal lymph node, and paraortic lymph nodes in the abdomen. So these are the lymph nodes. In intrathoracic only I asked because you are showing the mediastinal lymph nodes. So, and that may think of the tuberculosis one. Second possibility is the lymphoma or non-Hodgkin or Hodgkin's lymphoma. So we cannot think of the leukemia here. Acute presentation only, leukemias generally. Okay, next.
Pericardial synthesis was done where the 500 ml of pericardial fluid was aspirated. It was sent for analysis. Glucose was 114 milligrams per deciliter. Proteins were 5.7. ADL levels were 64.2. LDH levels were 984. Gram stain was negative, and pericardial fluids for AFB and CBNAT were negative, and it was also negative for malignant cells. And flow cytometry, it showed no abnormal precursor cells.
Is that fluid, pleural tap fluid is?
Pericardial fluid is hemorrhagic fluid.
Hemorrhagic. When hemorrhagic is there, you have to rule out the malignancy also.
Malignancy.
Yeah, always you have to rule out along with this biochemical analysis. Can you say the CB0 is negative? Can you rule out the TB?
No, sir.
Huh? No, it is not always.
Always.
You may not get the CB0 positive in a pediatric tuberculosis. Don't think like that in like adult tuberculosis. So is it exudative or
hemorrhagic?
It's hemorrhage, yes. With this pleural fluid analysis, what is your conclusion? You come to what conclusion with this?
In this, it is a hemorrhagic pleural effusion with elevated ADA levels and elevated LDH levels. So it could be tuberculosis.
Proteins are raised. No, that is proteins are raised.
Proteins are raised.
That is most important. No, exudate.
Exudative.
Hemorrhagic. Okay, next.
ANA profile.
The bedside test will confirm. Bedside test to confirm the tuberculosis. Bedside test. For this, the pleural fluid or CSF fluid. What test will do?
Cobweb.
Yes, cobweb. And any other test is there? Okay, cobweb. Okay. Pandis test, no?
Hmm.
Pandis for CSF. Okay. Okay,
Okay.
great. Good.
ANA profile was negative, thyroid profile was normal, and blood culture was negative. So diagnosis, tuberculous pericardial effusion with mild pleural effusion.
How do you
Mild,
treat this? Can you tell me?
Ma'am?
How will you treat this?
It is an extrapulmonary tuberculosis, and with any now like any new clinically diagnosed or microbiologically confirmed extrapulmonary TB, it is treated with 4 HRZD plus HRE, 2 HRZD plus HRE
4
for
HRE.
9 to 12.
Yeah.
9 to 12 months.
can you add steroids?
Along with steroids for 4 weeks.
Yeah, steroid indication. Tell me the indications of steroids in tuberculosis.
Tuberculous meningitis,
Yes.
endobronchial tuberculosis,
Yes.
miliary TB,
Yes.
and pericardial effusion.
Yes. Good. And the pericardial effusions in the connective tissue disorders, is it a massive or the mild? And is it a sudden or is it a gradual onset?
It is generally gradual in onset, sir, and
Yes.
it cannot. It is generally mild to moderate, not
Mild,
massive pleural pericardial.
yeah, mild pleural, that reaction is there, that immunological reaction. Like SLE is very commonly seen, no pericardial effusion in SLE, multi-organ dysfunction, no, in SLE. So there we'll get the pericardial effusion, and they may end in a dyspnea and breathlessness, very severe, and may have the congestive heart failure also. Okay. Anything, Preeti, madam?
Okay, so nice presentation. We applaud Monica for her good presentation and worked up case.
Thank you.
It's great work of Srinivas Murki sir and Karthik. So nice presentation. Only thing you need to know about the all the how to diagnose in National Tuberculosis Eradication Program for the PGs. I'm telling you need to know what are all the criteria, how to pulmonary, extrapulmonary tuberculosis. You should know about what is the definition of a contact, what are the indications of steroids, when do we give steroids, and other supplementation. You told about the ATT, but you have not mentioned about the pyridoxine. You have to tell about the pyridoxine. You need to counsel. How long are you going to keep this child in follow-up? When you are going to ask them child to come? And when do we say it is a drug-resistant tuberculosis?
For follow-up, it is we have to call a child in 2 to 4 weeks.
For what all you will see?
It is a radiological, microbiological, and clinical criteria. Clinically, we have to see for the improvement of clinical features and also weight. If there is any weight loss, there has to be 10% increase in the weight loss, weight gain, and along with clinical improvement. And radiological criteria, we can repeat the X-ray after 2 to 4 weeks. If it is 4 weeks, if it is if it is normal, then we have to repeat the X-ray at the end of the treatment. And microbiological criteria, we have to repeat the smear after the intensive phase and also at the end of the treatment.
Yeah.
So clinically follow up, no,
2 to 4 weeks.
Which is most important, reliable, that history itself also they can tell. You are telling radiological, pathological, but clinically, no, they will tell us.
Clinical improvement in the appetite and
weight gain. No, appetite. Regaining of the appetite is most important, along with the subsiding of the symptoms. That is most important. And Monica, you have presented very nicely. I thank the Dr. Srinivas Murki sir on in the guidance and Kirti. And your flow of presentation is very nice, and the participation in the discussion, and this is the way, though you are knowing that the diagnosis, how you are participated in the discussion is very, very important for a PG. student or DNB or MD or MS, whatever that. That is the most important. Though you know the diagnosis and openly, you can say that tubular vision should not have. We should have the differential diagnosis and synthesize the symptoms. Analysis of the symptoms and science is very, very important, and give the priority for the diagnosis. And you have to think of the commonest condition in Indian scenario or Pakistan or Bangladesh, like that, Asian countries. So sometimes unusual presentation may be there of the common diseases also. Atypical presentation, a rarity of the presentation. So that is the aim of the presentation in a clinical meeting or PG clinics. So that very good you have presented and you have given a very good answer. And I thank Dr. Srinivas Murki and other Dr. Kiran, or what is his name, and
Kiran Karthik.
Dr. Bhaskar sir. Yeah, Karthik. So very nicely you have presented. And the most important, the discussion is important. What do you want? We want that only. How you are giving the answers, interaction, that is the most important. Okay, sir.
Thank you. Thank you.
Thank you, ma'am. Thank you, sir.
Thank you, one and all. It was really a very interesting case and presented well by Dr. Monica. And the discussion went on for 80 minutes. Truly 80 minutes, not even 1 minute short of 80 minutes. And the very good friendly suggestions given by our senior lead discussants. They had given you tips, they had given you suggestions to all the postgraduate students. I'm sure they'll be very useful in your final year examinations. And the message given by our lead discussants is clinical approach to the case is more important than the investigations or the final diagnosis. Once again, I sincerely thank the lead discussants, Dr. T. Anand sir and Madam Dr. Preeti, and the guides, Dr. Srinivas Murki and Dr. Kiran, and as well all the participants who are sticking to the presentation. There are around 50 persons during this discussion. There are more than 150 on YouTube. So thank you, madam and sirs, for giving your valuable time, accepting voluntarily, staying away from your family members on this holiday. So thanks to all the participants. Now I request Dr. Monica to send us the abstract of the case that would be printed in our next IAPTCB journal.
You had a liver span, Monica. Liver span and the Tanner's scale also. Because adolescent, no, boy, that is most important. Madam already insisted.
CNS examination has to be done completely. You have to
3.
mention that. Because when you are talking about the Duke's criteria, we have that vasculitis will be there. Stroke can be in the criteria, in the Duke's criteria. So when you are thinking about stroke, microthrombi, vasculitis as a thing, then you have to see the CNS examination incomplete. It might be normal, but there can be a possibility. In total, you have to examine, right? And yeah, you need to know about the adverse effects of the drugs when you are giving ATT and adherence. So 2 A's always you have to remember when you are dealing with tuberculosis, adherence to the drugs, because sometimes they lose the interest in continuing with the therapy. So, and then they become defaulters. So that is there. And adverse effects of the drugs. So you have to tell them in prior, because the next day the child is going to come and say the urine is red and orange. So they will stop it off. They will stop off the drugs. So you need to tell about all the adverse effects of the drugs, what are all the complications of the drugs, and adhere to the treatment, which will be for 9 to 12 months. So long duration of therapies, chances of drop downs are there. So wonderful presentation. I thank the TCB team. Vamshi is there, Vamshi, Sri Krishna sir, and Sankoj Bhaskar sir. Thank you so much, the whole team, and Sri Shailam. So he has scheduled, he put the alarm, and he was there for the meeting. Thank you. Thank you, Anand sir. Thank you.
1 minute, Preeti. 1 minute, Preeti. I want to ask one more question to Monica. What are the side effects of the INH? When you are thinking of the adverse effects of all the ATT drugs, INH, you tell me. Rifampicin already madam told, and INH is very, very important. You have not given the treatment. No, that.
Peripheral neuropathy, sir. Pyridoxine you have to give.
Any other side
How
effect?
long are you going to give this pyridoxine? What is the dose and how long are you going to give it?
Pyridoxine we have to give, till
10
INH.
mg, 10 mg you give
we
along with
have
the
to
INH
give
and
along
at least
with
for 6
INH.
months. Remember, at least 6 months you are going to give pyridoxine. It's mandatory to give.
Yeah, any other side effect is there, Monica? You are not telling one more at the PG level. One more side effect is there. Optic neuritis.
Optic neuritis.
Yeah, don't think of only ethambutol.
Ethambutol.
It also can cause. These so many
Optic
papers they have presented in international
Yes.
journals and our Indian journals. So the optic neuritis also don't forget about the side effect of the INH. Only peripheral neuritis, everybody think 99%, but optic neuritis also very important. So thank you, Monica, and thank you all the team of the PCB, Dr. Sri Krishna and Dr. Sri Sailam sir, Dr. Bhaskar sir, and giving the opportunity to join in your as a moderator in PG clinics. Thank you very much, sir.
One last
Thank you,
comment,
sir.
sir. One last
Dr.
comment.
Monica, you can stop the screen share.
One last comment from my side.
Yeah.
I applaud the enthusiasm the lead discussants have today. They're more enthusiastic or on par with the postgraduate students. I feel if discussion is intended, our lead discussants are ready to discuss for another 1 hour. So that shows their enthusiasm to spread their knowledge to the upcoming pediatricians for the future betterment of child health. So my salutes to the lead discussants. I really appreciate. I don't know whether you had breakfast or not. This is your breakfast, I believe.
Thank you, sir. Thank you.
Thank you, sir. Thank you. We want to create the good learning center of pediatric in Hyderabad, sir.
Yes,
we want that. Our aim is that.
Yes, Center of Excellence.
At the national level should be a good learning center for PG level of this Hyderabad, Twin Cities branch. Especially, we want to elevate the flying colors. So we'll encourage.
No, it's a
South
Center of
India has
Excellence.
good reputation, sir. South India has good reputation. And I think as Telangana, we should project ourselves as a learning destination.
Yes.
Sincerely, sir, we have such a cream of academicians like you in Hyderabad. Unfortunately, it's not being projected at national level. And it is our firm belief that our academicians should be taken to the level of national levels, wherein you are no less than any other national speakers or national academician. Unfortunately, we are not in the limelight at national level. Probably the reason is we are not getting the opportunities. Dr. Srinivas Marke, are you there?
Yes, sir. He has to give some comment. Srinivas.
The man behind the presentation. Dr. Srinivas. Yeah. Now I request our treasurer, Dr. Vamshi, quite busy in his hospital. Dr. Vamshi. Dr. Vamshi. Yep.
Double duty ayanaku.
Vote of thanks, please.
Good morning, and I should really feel happy to be of the direction of Bhaskar sir and Dynamic RSV. I'm proud that we can say that TCB is doing wonders to bring the academic close to the youngsters like postgraduates, and it's a refresh movement on even on a holiday. Our central zone member and senior lead consultants, Dr. Preeti, senior professor, sir, and Srinivas sir is evergreen, like he's continuously giving us presentations postgraduate with his good clinical work. So, Monica, you had a great opportunity. I think you did wonderful. And Sri Sailam sir, RSV, Preeti madam, I really feel great because being a academician, you could take out some time. And sir, again, is a very senior Dr. Kiran and Murthy sir. Thank you. And special thanks to all the participants and who who try to learn today, especially postgraduates. I know they are very busy with their duty days. We for them, still they come and learn. So it's overall like we are very much privileged. Bhaskar sir, you are dynamic and we are happy to be a part of your team. So much. With this, I would like to conclude. Thank you so much.
Thank you.
Thank you.
Thank you, sir. Thank you. Good day ahead, sir. Thank you. Thank
Yeah,
you.
thank you. Thank you, one and all. Thank
Dr.
you.
Monica, you had cleared your pre-finals.
Thank you. Thank you.
You had cleared your pre-finals. Prepare for finals.
Yes. Thank you.
Namaste, namaste. Happy weekend. Enjoy the sun.
Okay. Thank you, Sri Excellence.
Thank you, sir.